Student, namaste. Myself Seema Agrawal, faculty at FPD. So today we are going to discuss clubfoot with you guys, and it is also known as CTEV, congenital talipes equinovarus. As you can see on the screen, that I am presenting here, sharing it with you. You can go through each and every words. Many of the words will be new for you. So in our Google Meet class, you can discuss if you have any confusion regarding these words and explanation. So please go through each and every concept and do hear me clearly, whatever I am explaining about the CTEV to you. So I'm starting the class now. Starting the explanation. So clubfoot is also known as CTEV, which means congenital talipes equinovarus. So if we will divide the words and try to understand what is CTEV, so congenital, as I know you all must know this word, present at birth. Talipes, it's a Latin word that means ankle or foot. Then equino, heel. Equino is a word which is also used in horses, so heel is elevated. The word equino means the elevated heel, and whereas foot is inverted inwards. Okay, so it's in inversion. Then incidence of the CTEV is 1 in every 1,000 live births. Like if 1,000 children live births take place, there is one childbirth will be with a CTEV, and it's a developmental deformity. And it is normally developing foot turns into clubfoot during the second trimester of the pregnancy. So second trimester means 4th to 6th month. Okay, so it's like whenever the baby is growing or is in second trimester in the womb of the mother, that is the time period when there is a chances of developing the CTEV, and it's rarely detected with USG. As you all know, you must have heard that the nowadays mother who are pregnant, they go with USG, ultrasonography, in every trimester of theirs according to their gynecologist. So before 16th week, it's rarely detected. Okay, so CTEV is a complex deformity with 4 clinical components. There are 4 types of presentation in the CTEV. The presentations are hindfoot equinus, you know, the forefoot, then midfoot, then hindfoot. If we will divide the foot into 3 portions, then forefoot, the toes portion and head of the metatarsal portion, then midfoot, the tarsals, the cuboids, and then other tarsals, and then the body of the metatarsals, and these are the midfoot. And then the hindfoot is our talus and back of the tarsals, that is the first row, navicular and calcaneum bones. So these are the hindfoot. So there are 4 components of CTV, 4 types of clinical presentation of CTV. First one is hindfoot equinus, like backfoot equinus. Then hindfoot varus, the hindfoot backfoot will be in varus deformity. Then midfoot forefoot adductus, the midfoot will be the bones, the tarsals there will be in adductus. And then cavus, there is a one more presentation, cavus. As the name suggests, it's in cave-like structure. Okay, so the arches will be increased, the middle arch will be increased, so it seems like cave. The foot is like this, flat, with some medial arch and the middle arch, then it will be like this, caves. Okay, now the pathoanatomy, how we will understand that what's the anatomical changes take place. So in equinus, our first one, equinus, severe tibio-talar and talocalcaneal plantar flexion will be seen. So our tibia and tala, the tibia sits on the tala. So tibio-talar and talocalcanean, you know, the base of the foot bone, hind foot is calcaneum. Above that sits the talus, and then above that our tibia sits. So it's like mortise, ankle mortise complex. So the severe tibio-talar and talocalcanean plantar flexion will be So you know, this is, if we will consider it as a foot, then this is dorsiflexion, this is plantar flexion. So foot will be in the severe plantar flexion, the hind foot will be in the severe plantar flexion. Okay, now the second type of component is adductus. What pathoanatomy, what anatomical changes we will see in adductus? It will be medial talar neck inclined. The talar neck, the neck of the talus bone, as you have must have studied in anatomy in first year. So the neck of the talar bone will be medially aligned. It will shift to medial direction. It will align to the medial direction. Then the medial displacement of the navicular and cuboid bone will be there. So other than talar bone, the other tarsals are involved here. The tarsals are navicular and cuboid. So the along with the medial alignment, medial inclination of the talar bone, the navicular bone and cuboid bone will also shift, will also displace to the medial direction. Then the calcaneus will be adducted, the distal calcaneus articular surface will be adducted, whole forefoot adducted in relation to the hind foot. Okay, so the whole of the forefoot will be adducted in relation to the hand foot. So this is the typical presentation of the adductus. Then varus deformity. What will happen in varus deformity? Adducted, plantar flexed, inverted calcaneus. So here the calcaneum will be mostly affected. So what would be its anatomical position here? It will be adducted, it will be plantar flexed and inverted. Okay. Then the fourth component is cavus. What we will see in cavus, as I have explained you in the presentation, the plantar flexed first metatarsal, the metatarsals, first metatarsal like our thumb, that metatarsal will be plantar flexed, severely plantar flexed. Okay, so these are the pathological anatomy of all the four components of the CT. Then plantar, then in clubfoot, the ligaments of the posterior and medial aspect of the ankle and tarsal joints are very thick and tough. So due to the disarrangement of the all the tarsals and metatarsals in different components of the CTEV, the ligaments of the posterior and medial aspect of the ankle and tarsals, whole side of the both the medial and the lateral ligaments will be thickened, and it will be taut in the equinus, navicular and calcaneal in adduction and inversion. The size of the leg muscles correlates inversely with the severity of the deformity. So size of the leg muscles, like our calf muscles, whole peroneal muscles, if we will see, like if what's written here is inversely related, like more the deformity will be, more less will be the muscles, less strength, less shape, less grossly the muscle size, the muscles bulk will be less. There is excessive pull of tibialis posterior abated by gastrocnemius and long toe flexors. So the tibialis posterior muscle will be excessively stretched, excessively pulled. It will be in excessively stretching position, and these muscles are shorter than the normal foot. जो भी हमारी normal foot होगी child की, जो CTEV से present हुआ है. So the muscles here in the CTEV foot, in the club foot, will be shortened than the normal foot. And in distal end of the gastrocnemius, there is an increase in the connective tissue rich in collagen, which tends to spread in the tendo-Achilles and deep fascia. Okay, so these are some anatomical pathological changes which we can see in the CTEV patient, CTEV child. Now, if we'll go through the classification, that how we classify the CTEV. So there are two ways of classification of the CTEV. One is the related to the cause of the deformity, and second in relation to the treatment stage. So like cause of the deformity की अगर हम बात करें कि क्या क्या causes है, उनके basis पे हमने CTEV को कैसे classify किया है. So they are like idiopathic clubfoot, secondary clubfoot idiopathic, like there is some changes, some idiopathy is there. Then secondary clubfoot, due to some other causes, clubfoot has happened. due to some underlying pathology, secondary to that pathology, the clubfoot has happened, then it is the secondary clubfoot. Then postural clubfoot, the clubfoot which is due to the posture, due to the malalignment, malposture, breaching position of the child in the womb, the clubfoot has occurred. Okay, so now on the basis of on the basis of relation to the treatment, the classification is on the basis relation to the treatment. If you will see in the relation of the treatment. So these are untreated clubfoot if it hasn't been recognized, okay, by at the time of the birth or during the developmental stage of the child. It hasn't been recognized and it hasn't been treated. So that type of clubfoot will be classified as untreated clubfoot. Then treated clubfoot, then resistant clubfoot. Resistant clubfoot means the clubfoot is not responding to any kind of the treatment procedure, whatever the conservative treatment procedure or even surgical treatment procedure we have been applying, the medical team have been applying, but it isn't responding well, the prognosis is not that well, then that type of clubfoot is called as the resistant clubfoot. Then a recurrent clubfoot. Recurrent clubfoot, as the word suggests, recurrent, that after the treatment there is some correction, there is some benefit, then again it appears, then again it happens, then again the deformity comes back, then it is recurrent clubfoot. Then neglected clubfoot. Neglected clubfoot, it means parents or the physician or the doctor knows that clubfoot is there, some treatments were given, but the whole procedure of the treatment, the whole process, the stages of the treatment, it has been neglected by the physician, by the medical team, or by the parents. So that type of clubfoot is do come under the neglected clubfoot category. Then the complex clubfoot. Complex clubfoot, we can say that we have done the surgical management, but there are some other pathologies are present. There are it doesn't have only one type of clubfoot. It has like more than 2 or 3 components of the clubfoot. So that type of clubfoot is called as complex clubfoot. Then how we decide the severity of the clubfoot? What is the assessment procedure? First, at the time of the birth only, the physician, the person, the nursing staff, or the physiotherapist, if they have the availability, has the role of assessing the child at the time of the birth, just after the birth, for the clubfoot and other congenital deformities. Okay, so that time if the deformity is seen, then or not even that time, even like if it has been missed at that time, then parents comes later on, they have observed it at home, at their home, after 1 month or 2 months or after 15 days or even after 1 year, when the child has to be started walking but he cannot walk, or there is some like visible change in his leg, in his foot, whenever he places his foot. So at that time of assessment, when the parents with the child comes to you physiotherapist, or to any clinical physician, so they must know what the severity is, how much the severity, and how we manage the severity, how we score the severity. It's on the Pirani score. There is a score which we use for to measure the severity of the CTE. So what's a Pirani score? It's a reliable method for assessing the amount of deformity in the clubfoot. The process is formulated by Dr. Safiq Virani. A child's total score here is in between 0 and 6. There are 6 signs that are assessed, and each is scored from 0.5 and 1 and so on. So depending on the severity, total score of 0 is no deformity, total score of 6 will be the severe deformity. So total score composed of what it is comprised of: hindfoot contracture score between 0 to 3, posterior creases, empty heel, rigid equinus, midfoot contracture, score between 0 to 3. Then again medial crease, lateral hip of the talus, lateral curved lateral border. So in this way, there is the scoring is done, and then the severity of the CTEV and the treatment will be decided on the severity score. Now, what other assessment procedure we use is X-ray. On the X-ray, we see the alignment of the bone, the angles, the normality range. We know that at what angle the talus and calcaneum, then other tarsals, cuboid, navicular should be placed, then metatarsal head. So on X-ray, we see how much misalignment, medial shifting or adduction has happened, and how much the angulation has changed. So X-ray evaluation is one of the basic evaluation and necessary evaluation for the CTE. And other than that, what we physiotherapists will assess, as I have discussed in pathoanatomy, the muscles. Muscles will also be compromised along in the CTE. So the strength of the muscles, the integrity of the muscles, comparison of the muscle girth from the normal limb. So these are the assessment a physiotherapist must have done. Or what are the functional defects if the child is coming in his developmental or walking phase or learning of the walking phase, motor developmental skill phase. So he has started walking, but he's not able to walk or sit or stand properly due to the club foot. So the functional defects, whatever the functional defects the child is facing or the parents are complaining, you have to assess that and maintain the record of that also, so that when you do the rehabilitation, you can compare your treatment protocol, your treatment prognosis, that what functional gain you have achieved and what were the defects and what are the changes you have achieved now. So in this way, we will do the whole assessment procedure of the CTEV child. Now the treatment. If we will go to the treatment part, then treatment is basically two types: non-operative treatment and operative treatment, conservative and operative. There are only two treatment protocols we follow for the CTEV child. Most widely used first line of treatment is always non-operative treatment, because the child is in growing phase. If it is early detected, the bones are very supple, they are soft, they have all their primary secondary growth plates not developed yet. So there are chances that it will be corrected with some conservative treatment, with some positioning, proper positioning, with some reductions. So the first line of treatment is always non-operative treatment. Okay. So most widely accepted technique is Poncetti treatment. Okay, Poncetti conservative method. And what it is and what it consists of. It consists of weekly serial manipulation and casting during the first week of the life. If the child or the CTEV has been detected at the time of birth only, then it is too much easy to do this whole procedure. The Poncetti method of casting consists of two phases. First phase is treatment phase, and the second phase is the maintenance phase. Treatment phase should begin as early as possible, optimally within first week of the life. It consists of gentle manipulation and casting done weekly. Every week, the manipulation will be done. The alignments, misalignments, rearrangements of the bones, shifting or medial displacements of the bones will be aligned, and then in that position, in corrected position, the casting will be done. Then again in the next week, the child will be asked to come with their parents, parents will be asked to come with their child. Then again the manipulation will be done, correction will be done, then again casting will be applied. So the order of correction by serial manipulation and casting should be as follows. First, the correction of cavus will be done if the cavus is present. Then the correction of adduction if adduction is present. Then the correction of heel varus if the heel varus is present. And at last, the correction of hind foot equinus. So it's if there is only hind foot equinus, then we will go for correction of that only. But if it is a complex, or all the talus we are saying that they are misaligned or rearranged, so we will go through the whole procedure. Okay. And mostly the whole procedure is like followed so that proper result or proper prognosis can be done. So each cast hold the foot in corrected position, allowing it to reshape gradually. Okay, so correction is there, manipulation is there, and it allows the body to reshape itself. Generally 5 to 6 casts required for correction. So it will take 5 to 6 manipulations or 5 to 6 weeks for the correction or treatment phase, because 5 to 6 casts required for the correction. And then the maintenance phase will be there. Casting will be like after that 2 weeks casting will be done. Then mother will be educated for the manipulation and things, and then maintenance of the corrected position with some orthotics device, and others will be advices. Now the complication of the casting. What are the complication we see in the child because of the casting? So it is very common. I know you will know that. Pressure ulcer, skin allergy, swelling, cast sleep, circulation problem, rocker bottom foot, and muscle atrophy. We can see due to the prolonged casting. Then we will discuss the operative management. In operative management, there is tendinoplasty, then osteotomy, then open surgery for the alignment of the bone. So there are Elizarov technique. Then there are so many types of operative methods that has come nowadays, and mostly operative procedures are done in recurrent club foot or neglected club foot or non-treated, untreated club foot. If the club foot is detected in early stage, mostly it is treatable with the conservative method only. And if the child has already crossed his developmental phase, the secondary growth plate has been fused, and still the club foot is present, then the medical team, medical experts has to go through the operative method. And after the operative method, again we physiotherapists come in role, and we have to do the rehabilitation, the muscle strength, the strengthening, the stretching of the shortened muscles, and then walking, like gait training, proprioceptive training. So there are lots of things, lots of rehabilitation the child have to go through after the operative management, operative treatment. So hereby I'm ending this explanation, this lecture on CTV. I hope you all have understood it, and if you have any queries, any any confusion, you can ask me in our Google Meet problem solving class. Thank you.